Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Up to 50% of the giant paraesophageal hernias sitting in your waiting room right now are they're entirely asymptomatic.
Right, 50%. It's wild.
Yeah, and as a surgeon, your immediate visceral instinct is to fix the anatomical defect. You see a spleen or like a colon in the chest cavity on a CT scan, and everything in your training just screams at you to pull it back down.
Oh, absolutely. Close the hiatus, fix the hole.
Exactly. But today we're looking at the modern clinical guidelines that explain why, putting the scalpel down might actually be the smartest, most evidence-based move you can make for your patient.
Yeah, because the evolution of foregut surgery has completely shifted how we evaluate these defects. We are no longer just treating the mere presence of a hernia.
Right.
We're treating the specific physiological and mechanical downstream effects of that hernia. And those effects, well, they vary wildly depending on the exact anatomical presentation.
For sure. And for all the surgeons, doctors, and medical professionals listening to us today, we know your schedules are packed. You need high-yield, actionable insights, not, a basic anatomy review.
Right, exactly.
So, before we begin, a quick note. This content is for reference only. Please ensure you always follow local guidelines in your clinical practice.
Good to get that out of the way.
Yeah. So the mission for today's deep dive is to systematically break down the modern anatomic classification of hiatal hernias. So that's types I through 4.
Yep.
And we really want to sharply define the current indications for surgical intervention versus watchful waiting based on the latest consensus statements.
Okay, let's unpack this. The entire classification system really hinges on two structural landmarks, doesn't it?
It does, yeah. The clinical pathway is entirely dictated by the spatial relationship between the gastro-oesophageal junction, the GEJ, right, and the gastric fundus.
Right, relative to the diaphragmatic hiatus.
Exactly. And this classification, it isn't just academic nomenclature. It fundamentally changes your operative threshold. Okay, so let's start with the overwhelming majority of your clinical volume. Type I, the classic sliding hiatal hernia.
The most common one.
Right. So the GEJ migrates above the diaphragm into the posterior mediastinum, but the stomach actually maintains its normal longitudinal alignment, right? The fundus stays inferior to the GEJ.
That's right. And this accounts for, greater than 90 to 95% of all hiatal hernias.
Wow, 95%. So the structural orientation is essentially intact. It's just physically displaced cranially.
Yeah, exactly. Because the phrenosophageal ligament has stretched and allowed that upward migration. So you lose the extrinsic compression of the crural diaphragm.
And that's a big deal.
Huge deal. The lower esophageal sphincter, the LES, it relies heavily on that crural pinchcock mechanism, to maintain a high pressure zone.
So when the GEJ slides into the negative pressure environment of the chest,
the valve fails. It just fails.
Which means we are dealing with a chemical problem. We aren't really worried about obstruction here, are we? We're worried about the constant, unchecked bathing of the distal esophagus in gastric acid.
Spot on. The clinical picture is completely dominated by severe esophagitis, Barrett's esophagus, and, those extraesophageal manifestations.
Right, and those extraesophageal issues often drive the most frustrating clinical presentations for you guys in the clinic.
Oh, absolutely. We see chronic cough, adult onset asthma exacerbations, severe laryngitis.
Because of the microaspiration.
Exactly. Acid microaspiration triggers vaguely mediated bronchospasm or it directly bathes the vocal cords. The chemical damage extends way beyond just the mucosal lining of the foregut.
So it's basically like a sliding glass door that won't stay shut on a stormy day, right? Like the door's structure is intact, but the acidic weather keeps getting inside.
I love that analogy.
Yeah,
that is exactly what's happened.
So if we're dealing with a failed pressure gradient, my threshold for the OR has to be incredibly strict.
It does.
If I'm reading the consensus guidelines from groups like SAGES correctly, I'm assuming we never, under any circumstances, repair a type I hernia just because it shows up on an endoscopy or like a barium swallow.
Never. A sliding hernia in the absolute absence of objective reflux disease requires zero surgical intervention.
Wow, zero. So the anatomical defect alone is basically meaningless without the clinical syndrome of reflux.
Correct. The decision to operate is driven entirely by the severity of the reflux and the failure of medical management. So the accepted indication for surgical repair starts with objective, documented GERD that demonstrates inadequate symptom control despite optimal proton pump inhibitor therapy.
And optimal therapy isn't just, a standard morning dose of a PPI.
No, definitely not.
The guidelines specifically note this means failing twice daily, BID dosing.
Yeah, bid dosing.
Oh, right.
If a patient is breaking through a maxed out PPI regimen with intractable symptoms, then, and really only then, surgical reconstruction of that valve is on the table.
Got it. But what about the complications of the acid damage itself, like the physical damage?
Well, if the disease process has progressed to, say, recurrent peptic strictures requiring dilation, or recurrent esophageal ulceration, or dysplastic Barrett's esophagus,
Then you go in.
yeah, surgical intervention is strongly indicated there. You're operating to halt the progressive mucosal destruction.
Makes sense.
Furthermore, if you've rigorously excluded all other pulmonary or ENT causes for those extra esophageal complications we talked about, the asthma or the cough.
Right, you have to rule out other causes first.
Exactly. And if they're refractory to medical therapy, that also serves as a really robust indication for surgical repair.
There's also this kind of nuanced shared decision-making pathway here, isn't there?
Yeah.
Say you have a younger patient, objective GERD is documented, and they actually respond beautifully to PPIs.
Right.
But they just want to avoid a lifetime of pharmacological suppression, like they don't want to take pills for 40 years.
Yeah, and operating to replace the need for lifelong medication is actually a validated indication. Yeah. We know chronic PPI use is associated with, well, theoretical risks regarding bone mineral density and potential renal issues over decades of use.
Sure.
So if the patient prefers a mechanical solution to their chemical problem, an anti-reflux procedure with a hiatal hernia repair is perfectly appropriate, provided, of course, their symptoms are proven to be acid-mediated.
Okay, so instead of looking at a type of hernia like a simple structural defect, it really makes more sense to view it as a failure of fluid dynamics.
Fluid dynamics, exactly.
The one-way pressure valve mechanism has failed because it lost its external crural support. You aren't operating to fix a hole, you're operating to recreate a high-pressure zone and stop the corrosive fluid leak.
You nailed it. But, clinical presentations rarely stay in these neat little boxes.
Of course not. So what happens when the acid isn't the primary threat? When the valve actually works, but the anatomy twists?
So that transitions us right out of the realm of chemical damage and directly into mechanical threats.
The type...
Yeah. We're talking about the pure paraesophageal hernia, or PEH, type 2. The anatomical setup here completely flips the script.
How so?
Well, the GEJ remains firmly anchored in its normal intra-abdominal position, tethered by an intact posterior phrenosophageal ligament.
But the anterior defect in the hiatus allows a portion of the gastric fundus to herniate upward, rolling adjacent to the esophagus.
Exactly. It's a rolling hernia. And because the GEJ remains competent and intra-abdominal, the high-pressure zone is generally preserved.
Oh, so they aren't getting reflux.
Right. These patients are not walking into your clinic complaining of classic heartburn or regurgitation.
Okay, so what's fascinating here is how the diagnostic focus must immediately shift from managing acid to monitoring for ischemia, obstruction, and volvulus. A totally different clinical mindset.
A completely different mindset. The patient presentation is entirely different. We were looking at severe postprandial chest pain, profound early satiety.
Because the stomach physically cannot expand,
Yeah.
right?
Exactly. And dysphagia, as the rolling fundus compresses the adjacent esophagus. And also very specific, insidious iron deficiency anemia.
Right, the anemia. The sources consistently point to Cameron ulcers as the culprit for this. Let's dig into the actual pathophysiology of how those ulcers form. It's fascinating.
Cameron ulcers are they're a brilliant example of chronic mechanical trauma. The herniated portion of the stomach is constantly riding back and forth through the rigid ring of the diaphragmatic crust.
It was seesaw.
Yeah, and every single respiratory cycle, we're talking 20,000 times a day, the diaphragm contracts and acts like a vice, just rubbing against those gastric mucosal folds.
Whoa.
Yeah. This relentless friction causes localized ischemia and linear erosions on the crests of the mucosal folds. It creates this slow, hidden ooze.
So they aren't throwing up blood.
Rarely.
Right.
The patient rarely presents with overt hematemesis or melena. They present with profound fatigue and an unexplained drop in hemoglobin.
Wow. But beyond that chronic slow bleed, the acute risks are terrifying. The guidelines dictate a much more aggressive posture here, don't they?
Very much so. The baseline recommendation is that any symptomatic paraesophageal hernia warrants surgical repair.
Any symptomatic one.
What's fascinating here is how quickly a symptomatic type 2 can escalate to a surgical emergency.
Right.
If the patient is experiencing chronic obstructive symptoms, recurrent pain, or that anemia we just outlined, elective repair is indicated. But the true specter Hanging over a type 2 hernia is the acute gastric volvulus.
Right, the volvulus. When a patient presents to the emergency department, we're looking for a very specific triad of symptoms indicating a volvulus: severe chest or epigastric pain, violent retching that fails to produce any vomit, and the absolute inability to pass a nasogastric tube into the stomach.
The mechanics of that triad are critical to understand. The stomach is rotated, typically along its organoaxial or mesenteroaxial plane, effectively creating a closed loop obstruction.
Just twisted on itself.
Right. The pylorus and the GEJ are twisting against each other. The patient retches because the stomach is immensely distended and irritated, but they can't vomit because the anatomical exit is kinked shut.
And that kink is the exact same reason the NGT hits a physical wall and curls back up the esophagus. You literally cannot navigate the tube past the torsion.
You can't. And once that torsion occurs, venous return is compromised first, leading to massive engorgement and edema. Eventually, arterial supply is cut off, resulting in transmural ischemia, necrosis, and perforation.
A total disaster.
Yeah. If you encounter that triad,
Yeah.
It is an absolute surgical emergency. You must intervene immediately to reduce the stomach, assess for mucosal viability, and resect if there's irreversible ischemia.
Okay, so a type A is a failed valve leaking acid, and a type 2 is a mechanical pinch risk. But let's escalate this further. What happens when the anatomical defect expands to the point where the anatomy just completely fails?
That leads us into the mixed and giant classifications, types 3 and 4.
So what's type 3?
Type 3 is the mixed paraesophageal hernia, combining the worst aspects of types 1 and 2. The hiatus has widened so significantly that both the gastro-esophageal junction and the fundus, often dragging the body or antrum of the stomach with them, have herniated into the posterior mediastinum.
Oh, man. So clinically, the patient is fighting a war on two fronts.
Exactly.
They have the displaced, incompetent GEJ generating severe refractory reflux, and they simultaneously have the massive rolling fundus creating a high risk for mechanical torsion and obstruction.
It's the worst of both worlds. For these type 3 patients, elective repair is heavily favored, assuming they're fit for surgery. You want to intervene on your own terms.
Rather than waiting for it to strangulate.
Right. Emergency surgery for a strangulated mixed hernia carries a significantly higher mortality and morbidity rate compared to a planned elective laparoscopic repair in an optimized patient.
Which brings us to the absolute extreme end of the spectrum, the type 4 giant paraesophageal hernia. We are no longer just dealing with a rogue stomach here.
No, we're not.
The diaphragmatic defect is so massive that other intra-abdominal organs are being drawn up into the negative pressure environment of the thorax. We're talking about the colon, loops of small bowel, the omentum, and even the spleen taking up residence in the chest cavity.
It's a huge problem. The physiologic toll of a type 4V hernia extends far beyond the GI tract. Because these abdominal organs are occupying substantial volume within the hemothorax, they cause direct compressive atelectasis of the lungs, typically the left lower lobe.
Yeah, patients are walking in with severe dyspnea, decreased exercise tolerance, and respiratory compromise simply because their lungs lack the physical space to expand during inspiration.
Add to that the severe chest pressure, rapid weight loss from the inability to eat, and recurrent aspiration pneumonias.
Here's where it gets really interesting. I am looking at a patient with multiple abdominal organs crushing their left lung. Their anatomy is fundamentally deranged. But wait, if a type 5E hernia is taking up the chest cavity and compromising breathing, why wouldn't a surgeon just operate on site for every single patient?
That's a great question.
It feels entirely counterintuitive to leave a spleen sitting next to a beating heart,
It does.
Yeah.
But if we connect this to the bigger picture, we have to look at the intersection of statistical probability and surgical risk. This brings us directly to the dilemma of watchful waiting.
Right.
Decades ago, the surgical dogma was exactly what you just described. You see a paraesophageal defect, you fix it, because the fear of catastrophic strangulation was paramount.
But the sources highlight data that completely dismantles that dogma.
Completely.
Up to 50% of paraesophageal hernias are minimally symptomatic or entirely asymptomatic, often discovered incidentally on a CT scan for an unrelated issue.
And the true annual risk of acute strangulation or volvulus the nightmare scenario we fear,
Right.
is currently estimated at less than 2%.
Less than 2%. Wow.
Hmm.
That specific metric forces a rigorous recalculation of our clinical approach, doesn't it?
It really does. Elective repair of a giant paraesophageal hernia is a major reconstructive operation. It carries non-trivial perioperative risks.
It's like,
Well, esophageal perforation, vagal nerve injury, splenic capsule avulsion, and serious cardiopulmonary complications.
so if I have an 80-year-old patient with significant cardiovascular comorbidities, and we happen to find a giant type 4 hernia on a scan that isn't really causing them any real distress, the consensus guidelines strongly advise against routine elective repair.
Exactly. Watchful waiting is the highly preferred strategy there. You're weighing a less than 2% annual risk of a catastrophic event against a highly probable immediate perioperative morbidity and potential mortality.
For that frail, asymptomatic octogenarian, the surgery is statistically more dangerous than the hernia itself.
Precisely. But, it's a highly individualized matrix. Let's take the opposite scenario. A 45-year-old marathon runner presents with a massive, entirely asymptomatic type 3 or far-Yi hernia found incidentally during a workup for something else.
Okay, so young and healthy.
In that younger, robust patient, the calculus shifts. Their immediate perioperative risk is very low because they are physiologically fit. However, their cumulative lifetime risk of encountering that less than 2% annual chance of strangulation over the next 40 years is quite high.
Oh, I see.
So after rigorous counseling regarding the operative risks versus the long-term anatomical trajectory, offering an elective repair to that 45-year-old is a highly defensible shared decision.
It's entirely about treating the patient's specific risk profile, not just reacting to the distorted anatomy on the imaging screen.
Yes.
Now let's briefly transition into the OR. When surgery is definitively indicated, whether it's for severe refractory GERD in a type 1 or mechanical obstruction in a type 3, what does the contemporary standard of care actually look like regarding surgical technique?
Well, the modern gold standard is a laparoscopic approach, and the sequence of critical steps is really well defined. First, complete reduction of the herniated stomach and any associated organs back into the peritoneal cavity.
Okay.
Second, and crucially, meticulous and complete excision of the hernia sac from the mediastinum.
Let's focus on that sac excision for a moment. Why is it absolutely vital to dissect that sac out entirely, rather than just pulling the stomach down and leaving the peritoneal lining in the chest?
The hernia sac is a lubricated serosal-lined peritoneal space. If you reduce the stomach, but leave that sac intact up in the mediastinum, you have left a slick, preformed anatomical tunnel.
Ah, so it's a highway right back up.
Exactly. The stomach will simply slide back up that pathway the moment abdominal pressure increases. Excising the sac completely untethers the distal esophagus, allowing you to achieve adequate intra-abdominal esophageal length without tension, and it forces the tissue to scar down, obliterating that potential space.
Okay, so following sac excision, you proceed with primary crural closure to physically reconstruct the hiatus, often using non-absorbable sutures.
Yep.
And finally, the addition of a fundoplication wrapping the gastric fundus around the distal esophagus.
A fundoplication is essentially mandatory in these repairs, but it serves slightly different primary purposes depending on the hernia type.
Right.
In a type I sliding hernia repair, the wrap is primarily chemical defense. It recreates the high-pressure zone to definitively cure the severe GERD that necessitated the operation in the first place.
But in the paraesophageal repairs, types 2 through 4, where GERD might not have been the driving symptom, the guidelines still recommend a fundoplication.
They do.
The sources indicate this is to reduce the incidence of postoperative reflux, which frequently occurs once you alter the hiatal anatomy. And importantly, it acts as a bulky physical anchor, right?
Yes. The wrap physically prevents the stomach from easily migrating back up through the recreated hiatus. It is worth noting, however, that the evidence quality supporting routine fundoplication in all paraesophageal hernias is acknowledged by guidelines to be relatively low.
Really?
Yeah, the nuanced decision of whether to perform a partial wrap like a toupee or door versus a complete 360-degree Nissen wrap must be meticulously tailored to the patient's specific preoperative esophageal motility.
So what does this all mean for daily surgical practice? If we synthesize the modern guidelines, the overarching philosophy is clear. Type I sliding hernias are strictly symptom-driven.
Purely symptom-driven.
If there is no refractory G or A or objective acid complication, there is no surgery. Keep the scalpel away.
Absolutely. Conversely, types 2, 3, and 4 paraesophageal hernias are driven by mechanical risk and obstructive symptoms. Any symptomatic paraesophageal hernia requires operative repair.
And an acute volvulus demands emergent, life-saving intervention.
Exactly. But for the truly asymptomatic paraesophageal hernias, we must step back, evaluate the patient's overall physiologic reserve, and seriously consider watchful waiting over immediate anatomical correction.
It is a profound shift from a purely structural mindset to a holistic, risk-based clinical approach, which leaves us with a final provocative thought to mull over before your next OR case.
Oh, I'm ready.
Since the type of fund application, partial versus complete, is highly dependent on esophageal motility to prevent postoperative dysphagia, how might the rapid upcoming advancements in high-resolution esophageal manometry fundamentally change our intraoperative decision-making?
That is the big question.
As our ability to map the exact contractile vigor of the esophageal body becomes more precise, the choice of the wrap might move from a surgeon's intraoperative preference to a highly standardized, algorithm-driven biomechanical requirement.
It's coming. The resolution of our preoperative physiologic mapping is eventually going to dictate the exact geometry of our surgical reconstruction. It forces us to act as both anatomists and fluid dynamic engineers.
It's incredible how much nuance exists behind a diagnosis we see every single week. To all the medical professionals listening, if you like this content, then do not forget to share with at least one of your colleagues or friends and spread the word. Also, check out our YouTube and other social media pages, and do check our previous season and episodes for some very relevant topics. Keep pushing the boundaries of your practice.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.